Hello, and welcome to another learning episode of the PJ Pod, brought to you by the Pharmaceutical Journal, the Royal Pharmaceutical Society's official journal. I'm Killen, and in this episode, which is part of the April 2025 digital issue, we'll be discussing the recently updated asthma guidance, which came jointly from the British Thoracic Society, BTS, the National Institute for Health and Care Excellence, NICE, and the Scottish Intercollegiate Guidelines Network, SIGN. Published in November 2024, the guidance, titled Asthma, Diagnosis, Monitoring and Chronic Asthma Management, makes several new recommendations about the pharmacological management and diagnosis of the condition. So for this episode, we wanted to find out more about the basis for these recommendations, their implications for the clinical management of asthma, and how these recommendations are already being integrated in practice. To do this, I asked consultant pharmacist in respiratory medicine, Toby Capstick, from Leeds Teaching Hospital NHS Trust, to walk me through the changes. The guidance is the first collaboration of its kind between BTS, SIGN and NICE. So the first thing I asked Toby was what were the benefits of these organisations coming together?
I think it's a really good step forward having a one joint national asthma guidance, because previously we've had the two guidance. We've had NICE as their independent guideline, and then we've had the BTS SIGN guideline that's been out and through various iterations for many years. And there was differences in recommendations and advice, and that just caused all sorts of confusions with different healthcare professionals. Should we follow the BTS SIGN? Should we follow NICE? So that was always tricky. And I think previously there were good things from the BTS SIGN guidelines, there were good bits from the NICE guidelines, and people were probably picking and choosing because of these two guidelines.
So it sounds like this joint guidance is really going to bring some consistency to asthma care. But now it's time to get into the juicy stuff and hear from Toby about the biggest changes that the guidance recommends.
The biggest and best step change is trying to move away from using the short-acting beta agonist SABA inhalers like salbutamol and terbutaline. This is going to be the biggest change in practice in the way that we manage asthma that we've had for a long time, and we're going to have to almost relearn how to manage asthma in many ways for a lot of healthcare professionals.
The impact that this is going to have on practice can't be understated, but it's also important to understand why this recommendation has been made.
Previously, what we found is our patients were using a lot of their SABA reliever inhalers, a lot of their salbutamol. And what we've become to understand more is that salbutamol doesn't actually treat asthma, it just relieves the symptoms. And if you use it frequently and regularly, it can downregulate your beta-2 receptors, it increases airway inflammation and hyperresponsiveness. And there's good data now from the SABA study showing that people who use salbutamol regularly have double the number of exacerbations.
Okay, so that's the why. But how is this move away from SABA use being managed in practice?
The way it's going to do that is it's recommending for our adults and patients over 12 years and over to use an ICS formoterol combination inhaler, and that ICS needs to contain beclomethasone or budesonide, and that can be used as your reliever rather than salbutamol. So it's a single inhaler therapy. And the real benefit from this is the formoterol component is a fast onset, long-acting beta-2 agonist. So it works about as fast as salbutamol, but lasts longer, so you get longer relief of your symptoms. But each time you use this inhaler, you get an extra dose of your inhaled corticosteroid, which can start to treat that underlying inflammatory damage that's happening in the airways and help get better control of the asthma, so you can prevent people having an asthma exacerbation before it's too late.
I actually have asthma myself, and I have to admit that I'm probably guilty of reaching for my SABA inhaler too often. So how can pharmacists communicate these changes to people like me?
Now, communicating that to patients is trying to change their understanding that a lot of our patients have had for many years, is that they use their preventer inhaler regularly and their blue reliever as an emergency. And now we're saying actually the ICS formoterol preventer inhaler, it's also a reliever. So it's one inhaler that does everything. It controls the asthma and it relieves the symptoms. This is a game changer for healthcare professionals, and we need to relearn how to manage asthma. But it's also for our patients who have been conditioned for many years, and we're guilty of that as healthcare professionals, to use their blue reliever as their reliever. But now we're saying, actually, you don't need to. So there's a lot of education for the patients to get them to unlearn that reliance on that blue inhaler and say, actually, this one inhaler will do the job of preventing, controlling your asthma, but also act as a reliever, and you'll need to use it less. And that'll take a bit of time for people to get their heads around, and a lot of education and support.
This communication may not be as straightforward for people whose first language isn't English.
One of the bigger concerns within the asthma community over recent years has been access to information for people from ethnic minorities where English isn't their first language, or they can't read English patient information leaflets. So one of my colleagues in Yorkshire, Dr. Killen Jones, has been doing a lot of work to improve access to materials in other languages. Now, it's not particularly widespread yet, but the Asthma and Lung UK website does have these asthma action plans for MART therapy and air therapy in a number of different languages, and that really is a big step forward in patient care for ethnic minorities, and hopefully that will continue and we'll see more resources available.
We'll make sure those resources are linked in the show notes. Next, Toby told me about how the recommendations on SABA use will impact patients on established therapy, and work that's already being done on this in his area.
We're implementing it a lot more in my area, and it's a slow burner. Now, the AstraZeneca have helped establish a project called Sentinel, which Mike Crooks over in Hull really promoted and piloted in his area. And they showed initially about 44% of patients who had uncontrolled asthma were able to switch over to MART. Now, we've built on that in Leeds and learnt from what's happened in Hull. And as we're getting more confident with using it, we're now getting 2/3, nearly 80% in some PCNs of our patients who are happy to switch over. And I think that is purely that we as healthcare professionals are getting more confident in how to talk to our patients, and that then means that our patients are happy to try this new treatment. And most people, once they go on to this single inhaler therapy, stay on it.
While there's definitely work to do in switching patients already established on therapy, it can be hard to engage these people.
We've always found that getting some of our asthma patients in for their annual reviews can be a challenge. And there's lots of reasons for that. There'll be some people who don't think it's a priority for them. But for a lot of people with asthma, they are in schools, they work, and actually taking time off to attend an extra GP appointment isn't always what they see as their priority, rightly or wrongly. And that's always going to be the challenge.
This was reflected in a survey of nearly 9,000 people from the charity Asthma and Lung UK, which found that 69% of people weren't receiving basic asthma care, such as an annual asthma review, an inhaler technique check, and a written asthma action plan. It may be hard to review some patients. However, Toby explained that it was important to prioritise certain people.
Pragmatically, if I've got somebody with asthma who is really well controlled, they don't use their reliever, their SABA reliever inhaler much, they don't have courses of prednisolone, so they're not exacerbating, I'm not as worried about those. The people I'm worried about with asthma are those who exacerbate. Every time somebody has an asthma attack, it's a failure of their treatment and puts them at risk of asthma death, because people die from asthma attacks, but also using a course of steroids puts them at risk of long-term harm from using a short course of their oral steroid medication. And also the patients who are using a lot of the SABA reliever inhalers, they're at higher risk of exacerbation as well. And people who don't use much of their preventers, again, they're at higher risk. They're the people I want to prioritise. They are my patients who I really want to see
It sounds like the people most likely to benefit from this change will be those already regularly visiting healthcare settings. On the subject of people with severe uncontrolled asthma, one thing that Toby felt was perhaps missing from the guidance was the recommendations around high-dose ICS.
One of the big things that we don't see in the latest guideline is in the main algorithm, we don't have a place for the highest doses of inhaled corticosteroid. And what the guideline now is saying, if you are still exacerbating on a medium dose ICS formoterol as maintenance and reliever therapy, then we should be looking to escalate their management. Now, some of that will be confirming that diagnosis, some of it will be checking for the confounding factors, checking their adherence. But if you've done all that and they're still not controlled, then we should be referring them on to a specialist who can then work with the patient, and we can start thinking about biological therapies to further control the asthma.
And the research comparing medium and high-dose ICS supports this.
We know these are cost effective, and this is where we need to be going. And one of the reasons why we do this is for the vast majority of people with asthma, using a high dose of inhaled corticosteroid is no more effective than a medium dose, but carries increased risk of steroid side effects. So the biological therapies are better at preventing exacerbations for most people than increasing inhaled corticosteroid.
So I think that nicely summarises the changes to the pharmacological management of asthma. Moving on now, the guidance also made recommendations on the diagnosis of the condition and the use of simple tests.
The thing we really have to remember is the objective tests that are recommended by the new guidelines, such as exhaled nitric oxide, the FeNO as it's known, and the blood eosinophil counts. They are not a single diagnostic test, and that's a thing that we just need to keep remembering. They support the patient history, they support a diagnosis. So the most important thing is to get that clinical history right and have the patients got signs and symptoms that are characteristic of asthma. So recurrent symptoms with diurnal variation, identifiable triggers that make asthma worse, be it some sort of allergen or stress or exercise. Context of a family history can also help, and also showing that there is no other causes for the underlying symptoms. You've ruled out other causes that could be contributing or causing the symptoms that we think are probably asthma.
While the majority of pharmacists won't be involved in the diagnosis of asthma, Toby explained that these recommendations could also support them.
So that history is key. And there's no reason why a pharmacist can't help with that and take that history. And that's something they really should be doing if we're talking to our patients within a clinic setting. But then the objective test will help support that. So if you've got a raised FeNO, raised exhaled nitric oxide, above 50 parts per million, that will support a diagnosis of asthma. If you've got a blood eosinophil count that is above the upper limit of normal, that will support a diagnosis of asthma. But there are other reasons why your exhaled nitric oxide or your eosinophil count can be raised. So you've just got to bear those other factors into play when making that diagnosis.
However, it's important to consider how readily available access to things like FeNO and spirometry are in primary care.
The FeNO machines do take a bit of capital investment, and there's lots of practices don't have access to this at the moment, and that's always going to be a barrier to having this implemented in primary care. So I would suspect that most GP practices at the moment don't have access to exhaled nitric oxide, so that's going to make it really difficult to use that as a really quick, simple test. But I know in primary care, access to spirometry has been difficult for a number of years, so there are big waiting lists, and some people can get it in more easily than others. But these are objective tests that pharmacists, if they're trained, can interpret these.
Since the guidance was published back in November last year, I was curious to hear how it had been received by pharmacists and other healthcare professionals.
Yeah, I think The pharmacological management, being single inhaler therapy with ICS formoterol, has been really well received by a lot of people in the asthma community. There's a lot of asthma experts who've been really advocating for greater use of ICS formoterol as MART and the anti-inflammatory reliever therapy for a number of years. And these have been recommended in international GINA guidelines for many years now. The UK has been a bit behind that. So for NICE to come out so strongly in favour of this as a way of getting people off these SABA inhalers and really conclusively confirming that this is the most cost-effective management of asthma has been really well received by experts.
While the guidance has been well received, that doesn't mean there aren't challenges with its implementation, the main one being the upfront cost.
I think the challenge, though, from commissioners is that it is a more expensive treatment. So a salbutamol inhaler is £1, £1.50 compared to an ICS formoterol, which is in the order of about £15 to £30, depending on which one you go for. So it is effectively we're investing in our patients to optimise their asthma treatment to prevent them exacerbating. And if we can keep people out of GP practices and out of A&E and hospital because of asthma attacks, that's where the cost saving comes in. So we know it's more cost effective, and it's up to commissioners really to understand that and coordinate those budgets in terms of drug spend and healthcare resource utilisation spend to reduce the financial impact overall.
So there we have it. This first of its kind joint asthma guidance is changing the way asthma is treated in this country. It has the potential to improve patient outcomes, bring consistency to care, and save the healthcare system money in the long run. I'd like to say a big thank you to Toby for walking us through the guidance with such clarity and reminding me it's probably time to book an asthma review. We'll leave links to the guidance and any other resources mentioned in the show notes. Please do follow the PJ Pod on whatever podcast platform you use and let us know what you thought of this episode on social media using the hashtag PJPod. And just before I let you go, if you're interested in joining the Royal Pharmaceutical Society to access a range of member benefits, including the pharmaceutical journals, news, features and learning resources, you can do so for the equivalent of just 60p a day. Just search RPS membership to find out more. That's it from us. Until next time, goodbye.